So we're going to be taping for shoulder everything, but incorporating some go-to massage elements here. The AC joint element, particularly when people are limited in AB adduction. And it's going to be regardless of the source of the dysfunction. It could be rotator cuff, it could be frozen shoulder, it can be all kinds of, doesn't matter. The most common symptom result related to mobility is not being able to go past 90 degrees here into AB adduction. All right, so my way of addressing that here is you just stabilize it. You're going to be stabilizing the joint, putting a little bit of pressure, trying to be kind of in between here, and then rule of thumb with mobility stuff related to this. If I was doing stuff at the SC joint related to flexion, thumb pointed in that orientation for flexion. It's not perfect, but it tends to have a person orient the bones of their arm, the humerus, in a way where it's not going to cause a pinch in the labrum. If they turn their hand over and try to go into flexion, that can be can offset the shoulder joint in a strange way. So rule of thumb, literally, thumb pointing in the direction of whatever shoulder movement usually puts you in a safe position for taking their arm to end range. Okay? Now here, I just can, and I usually actually do this in supine. One time I use my thumbs. But here I can apply a little bit, find a little spot there, okay? And then thumb this way, and then slowly up over your head, just as far as this feels comfortable. Slow. Her mobility is actually pretty good.
That's
A little limited there, and adjust to the barrier, and then come back down. Nice and slow. This is one where it requires a chunk of, this orientation requires a little bit more like just strength. You can use the pressure of like, you can get a little bit better leverage in supine for this, so it's not necessarily the best. Okay, again, now you're gonna push through me a little bit. Just a bit of resistance. And we're gonna see, did we get any change just off of doing that? Okay, now you just take over. Take it as far as is comfortable. Wow. What a thing. Okay, back down. That looked a lot easier. Did it feel more comfortable for you? Okay, one more time. Okay, push through me. Just through resistance, nice and easy. This is not probably aligning any joint. What it is probably doing is creating a little bit of space. And then as she moves through range, we're able to get some, probably not synovial fluid, it's probably hyaluronic acid. We're just lubricating the joint. And that just goes a long way. And just one to not forget. It's an easy go-to. Your palpation skills need to increase enough where you can start defining these areas, but I'm just trying to get my fingers as close to that little nook where I'm stabilizing and kind of pushing the clavicle forward just a touch, but really it's just pressure down, right in between, holding and having them go in and out of AB adduction and AD adduction. And if a little bit of resistance is part of it too, it tends to do good things. And it's really, you don't have to think that hard about it. It works pretty good for a lot of people. The other ones we can sprinkle in with this related to, I'm breaking the way, common patterns of distortion. Like we could get the chest wall open and all that, that's better in supine. But most people are always stuck a little bit too much in a scapular elevation. I would usually do this with a forearm. Table's also a little low, so why don't I listen to my own advice and bring it up. Form may be better here, but just so the camera can see. If we just get good pressure on both upper trap and levator scapula, here, so pressure, 10 minutes just right. Okay. Then you're just gonna do a little shoulder shrug up into me. So this is scapular movement, just scapular elevation. Okay, do that again. Hold, hold, hold. And then slowly let go But now once you fully relax, reach for your toes. Look for a nice stretch. If I wanted to exaggerate, I could take the pillow out and have her head go more into lateral flexion, create more of a stretch. Okay, again, shrug. Now keep holding. Let's incorporate breathing because these muscles can get involved with breathing. So big deep breath in, and then with the exhale, let go and reach for the toes. Good, fully relax. And then one more time, elevation with inhale. Trying to say, no, don't do that. Don't use your shoulders with your inhale. And then exhale with the reach down. It's the good form of depression. We're trying to get the scapulas into good depression. Okay.
So you let it elevate a little?
Yeah.
But not too much?
Yeah, I'm trying to just create resistance. We have inhibitory pressure plus resistance. So trying to tell it no, even though you will feel that, or if they're exaggerating it. It'll feel more profound and satisfying to like do that because you're getting that spot to change shape. So a person will want to do the big motion. We want the area to shorten. That way it's going to reflexively go into its eccentric action more effectively. So I want it to do a concentric action. Then it will be more willing, for lack of a better term, to when we relax, to allow for the eccentric lengthening. Lots of muscles just respond better by challenging them to do their shortening phase first and then the lengthening phase. They're used to, the body defaults to being like, if I do one, I should then be ready to do the other. So always doing both, especially here, it works great and it's really easy. In terms of better body mechanics, it just looks like this. Here's my forearm and then I have this hand for the resistance and then I can hold that shoulder down and keep them from elevating as much with it. So works great. All right, the anatomy we're working off of here. I'm gonna be taping just below the clavicle. I gotta navigate across this interior chest wall line, right? But then the biggest thing I try to tell people is to make sure they're coming low enough with that tape to actually cover the deltoids attachment. And where I tell you now, compared to what the sheet says, what the picture says, and what that model has, rather than doing this big giant U shape, to just do one that goes across, down, and then do another. Okay, that's gonna go across the front and the back of the shoulder. I also need one for right here. And that's gonna be the one I do. I'm gonna do this one first and then that one. Really the dominant muscle, the dominant mover for the shoulder joint here is deltoid. And upper trapezius should get involved some. So since those are more superficial, they're gonna be the ones I think about. And I have to just keep the anatomy in mind in that, upper trapezius is more posterior, not anterior. So I have to start a little bit more on the back of the neck and come over onto trapezius and then try to be right over top of AC joint. I'm gonna use that acromioclavicular joint as a place where I want some overlap. So I'm gonna try to be on upper trapezius. I have to stop where the hairline is. If I had somebody with no hair, then sure, I could put it all the way up on the back of the skull and that would be great, but you're not gonna have that option too often. One of the reasons why the tape doesn't work too well for a lot of neck issues, because where do you put it, right? But if I start more or less on the neck, as high up on the neck as I can, follow trapezius, try to go right over top the acromioclavicular joint, and then have it end wherever it's gonna end. Then that'll be a tape meant to help facilitate deltoid and upper trapezius when they do abduction. And I ideally am trying to tell upper trapezius to, my prayer into the tape is upper trapezius less, deltoid more. In terms of comparing upper body to lower body, the deltoid is the glutes of your shoulder. The deltoid should be strong and dominant, and it neurologically pairs with the glutes. So here, navigating around a strap, make sure I don't pull any hair. So go ahead and flex your head forward a little bit for me. And here's actually a case where I would take the pillow out. Let me try that. I'll just nudge it. There we go. That works good. The bungee just held it. All right, but now that has the neck on length. I'll flex it a little bit more forward for me. Perfect. Okay. So look, I can use the strap and just have it hold the tape for me. So you can work around that okay. And then I'm going to make sure I don't get hair. I want to be a little bit more posterior. Backing. Okay. Here. Good. Sure I didn't catch one in there. I did.
I can spare a few.
No, I know, but I'm not gonna rip. Come on. Come on. How'd you go so far? There we go. All right. That's the biggest challenge there. Once you're past that part, you're good to go. And here, I go above. Get the rest of the backing. Now, we're going to do a little bit. Thank you. We're going to have you reach for the floor a little bit. We're going to try to tape everything in the most ideal orientation possible. What it's going to turn into. So, scapula should be more depressed. The good version of depression. Here we go. Here. Got more of the backing. The whole time, I'm actually having her do a cool eccentric exercise of activating and lengthening what I ideally have be more short. So down. I'm going to have this be a big anchor. Good. It's a case where it's like a tattoo over a tattoo.
Right. Layer.
They don't
That's how
quite.
they cover
Maybe
up
they just
tattoos
smear
these
together.
days.
It's all just tape.
It's tape.
All right. So first one. Now for my small bracket. This is going to go right over the AC joint. Now when I learned this, it was just this one, the one that goes over the AC joint, and then the one that goes around and cups the glenohumeral joint. And they called it glenohumeral glide or something like that. And I ended up using this one the most. I mentioned the one client where I just had done it regularly. But it's the one where, for shoulder issues, there are some people where it can be incredibly helpful. The challenge with it is that you can't really do it yourself. They're really dependent on a therapist doing this with them, right? Okay. Now here, I just have to keep in mind making sure we're going to open the chest wall. This is the other value of doing this in, I jumped ahead. This one. Hit it. Here we go. The AC joint, find that spot. And here's the combo of incorporating this with massage, is if we got that joint more lubricated and moving better, then now hopefully all of this is there helping keep that adjustment going. Okay, and right there. This is one where I've really oomphed down. And you'll see why I want this one down at least before the last two, because those could easily go over top of those, right? Okay.
Now would it matter if you did that one first?
I don't
versus
think that,
second?
yeah. These two I think you could do interchangeably, and it would make little to no difference. So, I just need to pre-cut some of my anchors. There is a limitation, especially based on how good your scissors are, of how many pieces of tape you can cut at once. Don't get too brave, because then you'll start like having it roll over on itself and all that. I'm being a little sloppy with this, but oh well. It's a little bit easier to clean up than doing a bunch of, just doing the small corners, because then you'll have just these tiny bits falling off, so. All right. This one I've learned to do a big anchor, and I want it to cover just inferior to the clavicle. I'm trying to have this go over, frankly, pectoralis minor. I want to be trying to force that coracoid process back. So You'll never palpate that, but I want that scapula to have the impression of being rotated back into retraction. We have it depressed. Now I want it retracted and downward rotated. All right, so I'm going to go past here, underneath, make sure clavicle good. Then bring tape. Come here, you. Backing is really fighting with me today. Here we go. All right. Down. Okay. Other side. Now, this is one where I'm just trying to be honest with when I practice. This one coming across, I've learned to just 100%. So 75 to 100%, it's worth trying to, this is usually where people need the most adjustment in relation to their posture. It's the tendency to roll forward, to go into adduction and internal rotation. So I'm gonna have her turn her arm over into external rotation, and then I'm gonna go, gah! Make sure his skin is good. And I'm gonna keep coming, and then there we go. Then she can come back to neutral. Once I've gone across the chest here, and I've made sure that this tape isn't too low, because if it's too low, then it's just gonna be floating off the corner there, right? So now I'm just gonna make up the difference. I'm gonna have to steer a little bit away so the anchor doesn't go too much over top of the other one. That'll be just right. Okay. So you'll see a little bit in response to what Trish asked. That first piece of tape is there really on top of intermedial deltoid. And then this one's more on anterior deltoid, the next one's gonna be on posterior deltoid. So I'm trying to create like a three pieces of tape covering all three segments of deltoid to give it assistance. And if we cover that, all of this ideally maybe is creating the impression of a lift and some support, helping lift and hold the humerus onto the scapula. Thus, secondarily, supraspinatus would be given some breathing room. The supraspinatus is the one that's actually just deep, actually holding the scapula and the humerus together. So if we tape I don't tape in relationship to supraspinatus. I tape for deltoid and figure if I do that, this trifecta is just holding the whole arm up. And then supraspinatus is going to have an easier time. And then if it happened to be one of the other rotator cuffs, whether it be the subscapularis, infraspinatus, this is all covering that on some level. So any rotator cuff, anything, I'm like, well, I've covered my bases. All right, this one, I'm going to have the anchor, and this is just me making it up. Like, this is where the tape fell. I have to have the anchor be on the skin. I'm going to have this straighten your elbow. Go ahead and turn over just a little bit for me. I'm going to have the one anchor be on this side. Get my tape oriented more or less so it's over there. And down. Okay, good. Now you can relax. Now, wherever I end up over here, then I'm just going to make it up. But once I get past a certain point, I'm going to get a little tension here. Now what do I have to do?
Forward.
Yeah, she has to roll forward. So go ahead and roll forward for me. Okay, good. Now, this tape is it's going to end back here. So if I'm picking a direction and what to pretend to be, I'm going to pretend to be infraspinatus. If that tape had been longer, we could have brought it all the way over and had it be, excuse me, lower trapezius. Rhomboids are lower trapezius. But, okay. And right there is it. So, in terms of order, these two don't matter too much, but one from following upper trapezius over AC joint, right down the middle of the arm over medial or intermedial deltoid. Then one that goes right over top of AC joint and goes onto the anterior chest, posterior just wherever on the back. One that goes from the chest over to deltoid again, and then one goes from deltoid over onto the back.